Welcome back. It's my pleasure to moderate our final Future of Medicine 2023 presentation, The Opioid Epidemic, Addiction, and Harm Reduction. I'm Dr. Brent Schillinger, a past president of the Palm Beach County Medical Society and chair of the Society's Opioid Healthcare Response Initiative. We founded this task force back in 2017, the overarching goal to reduce opioid deaths in Palm Beach County. So this being the Future of Medicine Summit and the topic this hour, addiction, we're going to take a critical look at the future direction of addiction and addiction medicine. But to set the best course to understand the future, we need to reflect on the past. For the historical perspective, Dr. Erik Fisher, an addiction psychiatrist, bioethicist, and person in recovery. Dr. Fisher is an expert in addiction, and he has sought to make sense of addiction through a variety of lenses, not just science and medicine, but also through history, spirituality, philosophy, politics, arts, and literature. He is the author of The Urge, Our History of Addiction, that was published by Penguin Press in January of 2022. It's a very thorough history of addiction from ancient India and Greece to the present day, interwoven with his own personal experiences. Dr. Fisher received his MD from Columbia University College of Physicians and Surgeons, where he stayed on to complete his psychiatry residency. He is assistant professor of clinical psychiatry at Columbia, where he studies the role of neuroscience and psychiatry in society. After Dr. Fisher, we're going to look to the future, examining what we really need to do to make a difference. Dr. Jeffrey Singer will join us with that presentation. Dr. Singer is a senior fellow at the Cato Institute in Washington, D.C. He serves in their Department of Health Policy Studies. Dr. Singer has been in private practice in Phoenix, Arizona as a general surgeon for more than 35 years. He's a member of the Board of Scientific Advisors of the American Council on Science and Health. He served on the Advisory Board Council of the Center for Political Thought and Leadership at Arizona State University from 2014 to 2018. He's an adjunct instructor in their program on political history and leadership. Dr. Singer writes and speaks extensively on regional and national healthcare policy. He has a specific focus on drug policy, drug prohibition, and harm reduction, that is. He received his BA from Brooklyn College, his MD from the New York Medical College. He's a fellow of the American College of Surgeons. So without further delay, let's begin the presentation. First up, Dr. Carl Fisher.
All right, thanks so much, Brent. And thanks everyone for being here to talk about this important topic. I'm honored that you'd invite me. And I hope that looking at the history will be helpful. It certainly was helpful for me. I'm going to share my screen so that you can see some presentations here. I've got some visual aids that I think will help to illustrate some of the topics in the history that I'm interested in. But this is a topic that's near and dear to my heart. It's one small portion of the book that Brent referenced. And I'll just say at the outset that one of the big surprises to me when I started looking at the history and the philosophy of addiction over time is to find that there were epidemics throughout history. I thought that we were unique in a way. I started medical training during the opioid overdose crisis. It was slowly dawning on me as it was slowly dawning on the country, just the extent of this problem that's still with us today. And so it is a unique moment, but it also is a pattern of history. And if we understand that pattern, I think it can be useful in terms of guiding our policies going forward. I'll say at the outset, in terms of conflicts, that I don't have specific financial conflicts related to this presentation, aside from the book and speaking, including no relationships with pharma, medical device companies, insurance companies, or addiction treatment centers. So like I mentioned, when I came into addiction recovery myself, I started getting interested in the historical and philosophical basis of addiction. That was around 2019, 2010. This is a graph that I'm sure is familiar to many of you. It was a historic moment. It continues to be a historic moment in the history of drugs and drug problems. But the big surprise to me as I started looking at the history throughout time is that epidemics are nothing new. The drug epidemics are truly nothing new. They've been there for hundreds upon hundreds of years. I went back as far as I could, and even in texts dating back to 1000 BC, I found evidence of addiction in the Rig Veda, early Hindu scripture, there's a poem called The Gambler's Lament, which describes a man's descent into a case of unambiguous addiction. And just a brief example of this is when they say the gambler goes into the hall of play asking himself, will I win? I will win. The dice run counter to his desire and then eventually start to take control of him and his behavior. And we see examples of that with regard to alcohol, with regard to opioids and so forth. But what about epidemics? Epidemics are clearly and unambiguously in the historical record, starting from the early modern time, starting from the birth of transcontinental commerce, and really from the very first voyages of Columbus to North America. The first drug epidemic, if you want to call it that, which is clearly evidenced by attempts at suppression and control, started in the 16th century, in the earlier part of the 1500s and so forth, when Columbus's expeditions brought tobacco back to Europe. In those early years, tobacco was initially very briefly considered a special medical preparation. It was reserved for the elites. It was considered to be a sort of panacea by some doctors. It spread throughout the aristocracy and through those with privilege throughout Europe, and then it very quickly made its way down the so-called social ladder and became problematized, such that by the turn of the 17th century, in the early 1600s, we already see really bold calls for prohibition and what today we would call supply side problems or supply side controls. King James himself wrote a piece called A Counterblast to Tobacco. Many other English anti-tobacco writers talked about how it was a plague intolerable. So even before we had the notions of psychiatric medicine or addiction medicine that we have today, people were intuitively associating these drug problems with medical problems. Now, then as in now, people reach for single solution and relatively narrow prohibitionist responses to the problem. So in Catholicism, people were threatened with excommunication. The Ottoman Empire punished cases of tobacco use with death, and so forth and so on across all of Eurasia. And what this tells us is at least two things. One is that the evidence that people tried to suppress drug problems shows that it was out there in the society, developing and moving and continuing despite these prohibitions. And secondly, it shows us specifically that the prohibitions were not sufficient, that prohibition by itself was not a sufficient response to drug problems. That's just the first clear example of epidemics. The second one that some of you may be familiar with is the English gin craze, roughly 1720 to 1750. This was a case when the use of gin, especially by the lower classes in London, was a massive, massive social problem. People once again talk about it being epidemical, associating the problem with medical analogies. There were many contributing causes to the gin craze. And I just want to highlight that it wasn't just the case of the substance itself. First off, there are massive social problems for which people naturally could turn to substances that modulate their consciousness. So there's a growth of a dislocated and alienated underclass. There is a massive, massive social problems in the streaming hordes of workers coming into London. There was also elements related to the drug itself. So gin, of course, had been around before the 1700s, but advances in distilling technology and also just some of the raw materials becoming more available made it more novel, at least in the sense that it was much more easy to access. But going hand in hand with that second force is the role of what other scholars have called addiction supply industries. So this was around the time, along with the other factors in industrializing London and England, there was the growth of powerful distilling industries, which actively took a role in spreading the use of their drugs, of their products. In particular, regarding this third point, the addiction supply industries, there's one nice example. Daniel Defoe was actually a hack for industry. In addition to his other novels, he wrote a free trade defense of the distillers, where he said he basically takes a page out of a playbook that has been used over and over and over again by opioid manufacturers, by tobacco manufacturers, by other people who are involved in the production of potentially addictive compounds. He says that the excesses and the intemperance of the people is really an individual problem. The people will destroy themselves, but the spirit is wholesome and good. In other words, that the problem is not in the bottle, the problem is really in the people. And if people destroy themselves, then it's the magistrate's business. It's the problem of criminal law. It's not up to the distillers. So this is once again a notion that we see over and over again throughout history. So as I looked at the history of addiction, I found over and over again these epidemics across different societies. These are just two of them. Also, the United States had a terrific problem with alcohol in the Revolutionary period. There was the first American opioid epidemic in the 19th century, especially around the time of the Civil War. Just a bit later than that, cocaine. And then with the advent of the first synthetic drugs, particularly barbiturates and amphetamines in the early 20th century, we see epidemics of uncontrolled and harmful use. There were multiple opioid waves, especially in the middle of the 20th century, around the 1940s, 1950s, and so forth and so on. So just a few brief words about some of those other epidemics to illustrate some principles that I think are helpful for us today, that can point toward messages that we need regarding drug control policy, and especially with regard to the medical profession and the public health profession's role in how to respond to these epidemics. The first is that we have this alcoholic problem in the early American Republic, growing around the time of the American Revolutionary War, but then peaking in, say, the 1820s or so. And this was noted by many observers, noted by foreign ambassadors to the United States, and noted by Benjamin Franklin himself. The second quote is from Benjamin Rush, who is one of the founding fathers, a signatory to the Constitution, and a prominent doctor in the early American Republic. He is notable throughout medical history for, in a sense, problematizing problem drinking as a medical problem in and of itself. So previous writers had, within medicine and otherwise, had talked about drinking problems, but he really conceptualized a medical idea of habitual drunkenness as a disease unto itself. But it bears noting that he didn't say that it was totally up to medicine, or that medicine was the sole arbiter of what was right and what was good. He noted that there were social and economic contributors to the epidemic then as now. Secondly, let's talk about this early 19th century wave of epidemics. Around really from the 1920s onward, but throughout the good portion of the middle of the 20th century, there's a massive problem with opioids in the United States. And really the only place that modern medicine was working on the problem was this institution called the Narcotic Farm in Lexington, Kentucky. It is a fascinating place, really interesting for being sort of an island, an oasis in the middle of a desert of neglect, basically, for medical problems regarding addiction. This is also the time of William Burroughs, who published under the pseudonym William Lee in the early 1950s, his famous book Junkie. And around that time, the medical profession was so uniquely focused on opioids, they lost focus about other problems. So much focus on the drug itself sort of warped the medical perception of addiction. Opioids became the model for addiction, and it caused medicine to miss other problems in the drug policy arena, specifically this growth of amphetamines I mentioned before. So amphetamine developed first as an inhaler, which was there over the counter, and then later as tablets. It was marketed and provided to people with mild depression. The widespread use of amphetamines throughout World War II was capitalized on as a remedy for exhaustion or fatigue or depression. Methadone was used as part of psychoanalysis, and dexedrine was marketed as an antidepressant, and so on. So once again, the point is that when we focus too much on one drug, we miss the overall picture. And I'll leave it to Dr. Singer to talk more about this, but I think we have an element here where the opioid crisis today is absolutely a terrible crisis, and there's plenty of things that we could do to save lives. And we mustn't miss sight of the fact that there are other drugs out there in the drug policy arena. So returning back to this overall pattern of epidemics, and then I'll close because I see my time is running short. We have these waves of epidemics over and over and over again, and sometimes societies have responded compassionately and thoughtfully, sometimes societies have not. But regardless, one thing that we find across this history is that general medical treatment has been insignificant in the broader scope of stopping epidemics. In other words, medicine by itself is not powerful enough to stop a drug epidemic. We absolutely have an imperative to save lives, to do what we can on the margin to help. But I think our role is best conceptualized as compassionate medical treatment to save the lives that we can without overpromising in the policy arena. There's more that needs to be done there. And so one takeaway from this could be that we should take as our metric, we should take as our definition of success, not absolute control, not absolutely squelching any sort of drug problem, but how do we save lives and how do we make people's lives better? How do we actually meet them in a way that is going to solve their most urgent medical and other problems? So I'll leave it there. And once again, I'm honored to be here. Thanks for having me. And I look forward to further discussion.
Thank you so much, Carl, for that excellent overview of the history of addiction. Understanding the history is going to really help us figure out where we need to go with the future. And to give us a focus on policy, we have Dr. Jeff Singer, who is with the Cato Institute. He's senior fellow at the Cato Institute. Jeff.
Thank you. And that was a really fascinating presentation by Dr. Fisher. To pick up a little bit after where he left off, there was a really interesting study done out of the University of Pittsburgh School of Public Health and with researchers from the CDC by Jalal et al. Was published in Science in September 2018, where they were able to actually trace the current overdose problem back to at least the late 1970s. That's as far back as they were able to get the data. And they concluded that this current overdose crisis actually began at least as early as 1979 and has been on an inexorable exponential growth trend, at least since that time. The only difference over the last several decades has been which particular drugs are predominating among the overdose deaths at any given point in time. And then in 2019, a report for the Joint Economic Committee of Congress said actually the current overdose problem we're dealing with now began in 1959, although they weren't able to discuss whether they had evidence that was exponential. Now, one of the things contributing to it is what economists, the technical term economists use is the Alkean-Allen effect, or what we policy people call the iron law of prohibition. And a shorthand version of the iron law of prohibition is the harder the prohibition, the harder the drug. And we remember during alcohol prohibition, they weren't smuggling in beer and wine, they were smuggling in the hard stuff. Even in real time, when you're tailgating at a football game, you're drinking beer and wine outside in the parking lot, but you're not allowed to bring any alcohol into the stadium. They usually bring in the hard stuff in flasks. And that's because it incentivizes whoever's in the prohibited substance business to come up with more potent forms that are easy to smuggle in smaller sizes and then subdivide it into more units for sale for the risk they have to take. So the harder the government cracks down on enforcing prohibition, that actually is what leads to the development of harder forms of drugs. And you could just look at recently, after they cracked down on doctors prescribing opioids, and the prescription rate dropped about 60% between 2012 when it peaked until through 2019. There was fewer opioids available for diversion into the black market. So first, the void was filled with heroin, and then at around 2012, fentanyl, which had been relatively stable among as one of the drugs among the overdose deaths, began to start increasing as the cartels figured if they added fentanyl to heroin, they could boost its potency and therefore smuggle it in smaller sizes and get more bang for the buck. Eventually, the concentration increased, and then the pandemic actually had a lot to do with this. Because of border closures and supply chain problems, it was much more difficult to ship opium poppies across borders, and you need acetic anhydride to process the morphine from opium into diacetyl morphine or heroin, and there was a supply chain shortage of that. whereas you could just synthesize fentanyl in a lab with the fundamental ingredient piperidine, which is very abundant and available. So they switched out heroin for fentanyl, and now even with the supply chain issues no longer there, it just makes more business sense. But we're already seeing now reports on the East Coast, particularly of fentanyl being mixed with xylazine, the veterinary tranquilizer. Users call it tranq. And of course, that can't be reversed with a naloxone because it's not an opioid. And that's also there to boost the potency. And in other parts of the country, we're hearing reports of isotonitazine, part of a class of synthetic opioids called nitazines that has now made its initial appearance around 2019. The Tennessee Department of Health reported past September that overdose deaths containing nitazines increased fourfold in 2 years. So the iron law prohibition is working. So what do we do to reduce overdose deaths? Well, I'm going to take this position, especially because I work for the Libertarian Cato Institute, that obviously if we legalize drugs or we legalized alcohol, we'll be able to regulate it in the same way, and we'll make it so that people could know exactly what's in it. When I go to buy alcohol at my drug dealer, which is usually Total Wine, and I look for bourbon, if it says 45% alcohol, it never crosses my mind that it might have fentanyl in it, or it might be 50% alcohol. And so and of course, if I look young, they're going to card me. So that's, in my opinion, that's the ideal way. But politically, that may be very difficult. So some countries, starting in Portugal, have decriminalized. And of course, at least you're not putting people in cages for using unapproved drugs, and also destroying their futures by giving them felony convictions so they can't get a meaningful job and turn their lives around. But the downside of that is you still have a black market. So what they're purchasing on the black market, it's not safe. They don't know what's in it. They don't know even if it's what it says it is. How many times we're hearing stories about kids purchasing what they think is oxycodone on the black market, turns out it's fentanyl. So that's not as good. But even if we had my ideal solution, we will still need harm reduction. Alcohol is legal, and we need harm reduction for alcohol because there are always going to be people who develop problems with substance use disorder, and there's always going to be the need for people to take steps to reduce the dangers of using these drugs and the long-term harmful effects. This should come easy to all of us doctors, the concept of harm reduction, because much of what we do in the developed world is practice harm reduction. When we have a patient who, let's say, is overweight, has mild diabetes, high blood pressure, and hypercholesterolemia, and we can't get them to, go on a proper diet and exercise routine, where we might not even need to medicate them because for whatever reason, maybe they don't want to, or they're unable to. So when we prescribe statin drug, antihypertensive, maybe metformin, we're practicing harm reduction. We're not necessarily endorsing their decisions about how to live their life. But as doctors, we're saying, well, let me at least do what I can on my end to make your choice less dangerous and less harmful to you. So that's the basic concept. Now, what kind of harm reduction is on the horizon here in the United States? Well, first of all, one of the most important forms of harm reduction we could have in the United States is to allow people to test drugs. Every single state in the union, I have a paper out on this, came out in June 2022, every state in the union except for Alaska, interestingly, I don't know why, but they don't have it. They all have drug paraphernalia laws on the books. And then there's federal drug paraphernalia laws. Federal drug paraphernalia laws basically say it's illegal to transport what they list as drug paraphernalia across state lines. But states list paraphernalia that's prohibited in their states. And the great majority of them, and including the federal, list materials used to test illicit drugs. So if you, as a caring member of a harm reduction organization, decide you want to hand out fentanyl test strips to drug users so they can at least test what they bought to see if it has fentanyl in it. In many states, you can get arrested for handing out drug paraphernalia. By the way, the company that makes the fentanyl test strips now has xylazine test strips for people who are worried about xylazine being in what they bought. Many states are amending their drug paraphernalia laws to allow for test strips, although it would be better for them to allow for, just take out the word testing equipment, because there are always new developments coming down the line, including spectrometry units. And you don't want to have to go back to the legislature every time a new testing device comes out. So just get rid of the word testing. Ideally, get rid of the paraphernalia laws, because they're standing in the way of organizations that want to have, for example, syringe services programs and the like. Syringe services programs, many people know them as needle exchange programs. But in recent years, we've changed the term to syringe services, because they do a lot more than just give you clean needles to use to reduce the risk of HIV and hepatitis. Nowadays, they're handing out naloxone and handing out test strips. So again, getting rid of the drug paraphernalia laws gets rid of the obstructions to these types of harm reduction measures and to groups that are wanting to do this. But as a second best choice, at least make major modifications to the drug paraphernalia laws to allow organizations that want to do this. Another thing is what in Europe, this is very common. Harm reduction organizations have a way in which you could drop off the drug you purchased in an anonymous fashion, a sample of it. They'll test it with pretty sophisticated equipment and give you a report as to what's in it, so you know that before you decide to use it. And everything's kept anonymous. Again, that would be a violation of paraphernalia laws. Naloxone, the overdose antidote naloxone. I've been calling for, many doctors have been calling for it to be made over the counter for years. The FDA actually determined in 2016 that it's probably ripe to be made over the counter, and has been asking the pharmaceutical companies to ask them to reclassify it. They don't have to do that. They could just decide to reclassify it. But there's a certain amount of capture of the FDA by the pharmaceutical companies, and the pharmaceutical companies would much rather overcharge the third-party payers for the naloxone, because the experience is when any drug goes over the counter, it tends to drop in price. So, but it looks like in recent months, we've heard the FDA give signals that they maybe as soon as this month, or at least by next month, reclassify naloxone over the counter. That will make it much easier for harm reduction organizations to buy it in bulk. That you could put it in vending machines. You could have it out in the street in certain boxes for people. That's another way of reducing overdose deaths. Right now, the way states are working around it is most states have passed what they call a standing order thing, where either the health department director, who might be a licensed physician in the state, or any physician could sign a document saying, if anybody comes into this pharmacy wanting naloxone, I'm the ordering doctor, it's okay with me. But that's less than ideal. I was always asking for making buprenorphine, getting the X waiver requirement off of buprenorphine, which is a very good, tool for medication for opioid use disorder. Thank goodness in December, Congress actually removed the X waiver from buprenorphine. So now anyone interested in prescribing buprenorphine for substance use disorder doesn't have to go through all those hoops. Unfortunately, just a couple of weeks ago, the Drug Enforcement Administration threw a little monkey wrench into that, because they now say that if you were to get placed on Suboxone through an initial telemedicine appointment, which is permitted now, you have to get an in-person appointment with the prescribing physician within 30 days or you're cut off. Well, that's, right now the average wait time to see any primary care doctor in the United States is around 26 days. And many doctors who are treating substance use disorder, they're already overloaded with patients. I think that places an undue burden on people with substance use disorder. I don't think they should be a cutoff after 30 days. So that's an area that needs work. Three more areas I'll cover. Take-home methadone in the UK, in Canada and Australia since the 1960s. Doctors have been able to prescribe methadone for substance use disorder, just like they can prescribe buprenorphine now. And there have been a number of pilot programs in this country that showed no problems with diversion, good compliance by the patient. And of course, during the pandemic, SAMHSA allowed for a certain amount of take home because of lockdowns. And they're planning to make that permanent, where after 6 months of being on methadone, in a methadone clinic, if you're a stable patient after 6 months, you could have 28 days worth of take home. And if you're less than stable, which I think is 3 months or more, you could have 14 days worth of take home. Well, that's better than the way it's been. But it's, first of all, it's stigmatizing. You're treating people with substance use disorder differently than anybody else. They have to line up. They have to take the drug in your presence because they're quote unquote drug addicts who can't be trusted. There's a whole bunch of NIMBYism because people don't want these clinics with people with quote unquote drug addicts lining up in my neighborhood. So, and in some areas of the country, like for example, Wyoming doesn't have one methadone clinic. So I think it's a good idea for us to allow all doctors, any primary care physician who's interested, of course, any addiction specialist, but any primary care physician as well. Not everyone will be wanting to do this because to treat addiction, it's complicated. So you have to make a personal commitment to spend time with the patient, to follow your patient, to bring in other disciplines. So not everyone's going to want to do it, but allowing it so that, like it is in Canada, UK, and Australia, where primary care physicians who are interested in this can prescribe it, will make access to methadone treatment much greater. Now, there was a bill that was introduced on March 6th in the Senate. The co-sponsors are Ed Markey of Massachusetts and Rand Paul of Kentucky. In the House, it's I'm blanking on his first name, Representative Norcross of New Jersey and Bacon of Nebraska. So they're bipartisan in both houses, and it's called the Modernizing Opioid Treatment Access Act, and it would do this. Unfortunately, there are two drawbacks to it, but it's a great step in the right direction. One of the drawbacks is it will only allow board-certified addiction specialists to prescribe take-home methadone. Well, again, there are 5 in the state of Wyoming. That it's better than what we have, but it's not what I would like. And also, it follows the SAMHSA guidelines. So you're not allowed to prescribe more than a 30-day supply of methadone to anybody in this bill. I would argue, and I would hope most of my colleagues in the medical profession will argue, that when you put these strict limitations on how much you prescribe and the number and all that, you're really interfering with the clinical judgment of the doctor. The doctors know their patients, and some patients have been your patients for a long time. You know how much you can give them. I don't think that should be cast in stone. And then another thing we could do is make diacetylmorphine or diamorphine, brand name heroin, Schedule 2 and Schedule 1. There have been many programs. Right now, 6 countries, Switzerland, Germany, Netherlands, UK, Canada, and Spain, have a heroin-assisted treatment program where patients who failed methadone they're given in a supervised setting pharmaceutical grade heroin, which, by the way, is on the formulary in many countries. A pilot program here because it's Schedule 1. It's half the potency of Dilaudid, which is Schedule 2. I think if we made it Schedule 2 so that we could do some clinical studies on it, that would be a step in the right direction. And the last recommendation I will make is that we all probably know about centers. Some people call them safe consumption sites or supervised injection facilities. The first official one in the world was in Bern, Switzerland in 1986. I just had a paper come out on this. There are now 147 officially sanctioned overdose prevention centers in the world, in 16 countries, 91 locations. This is bringing people in off the street, giving them clean needle and syringe, helping them test their drugs, standing close by within the lock zone, and spending time with them. And it's been also very effective in connecting people, not just reducing overdose deaths and spread of disease, but it connects people and to social services and to drug addiction treatment services. In this country, it's illegal because they have 21 USC Section 856, also known as the crack house statute, been on the books since the 1980s, before there was such a concept as a safe consumption site. And so if you knowingly allow someone to use an illicit substance in your premises, that's a violation of federal law. In November 2021, New York City defied that, and they opened up 2 overdose prevention centers that by the end of 2022 had already reversed 750 overdoses. The state of Rhode Island passed a law authorizing private, self-funded overdose prevention centers. One is about to start this year in Rhode Island. So they're defying federal law, but we need to ideally get rid of the crack house statute, or at least clarify it to allow for overdose prevention centers. And these are the harm reduction tools that are at our disposal right now.
Well, thank you, Jeff, for bringing us up to date on some of the challenges we have in the policy arena when it comes to addiction and substance use disorder. So now it's time for question and answer. For those of you who are watching online, you can send your questions in by chat. Meanwhile, I will get the discussion going here. First question I have for Carl. Obviously, addiction's been part of the human experience for a long time, as you very well defined in your book, The Urge. You've also said, and you mentioned it on the program here today, that medicine, the practice of medicine today, is coming up woefully short in its treatment of addiction. So the question is, haven't we learned anything from this history?
Thanks, Brent. And I think this builds nicely off of what Dr. Singer said, that we have certain obstacles to the appropriate medical treatment of addiction. Some of that is the stigma, to put it simply, at the individual or personal level, but also at the institutional level against the appropriate treatment of people with addiction. But some of that stigma can be organized into laws or to other policies that obscure our ability to exercise our best professional judgment and just practice common sense medicine. I love what Dr. Singer said about harm reduction essentially just being good medicine, or at least that's one of the messages I took from this, that good quality medicine that is attempting to reduce people's burdens of drug problems and to help them with the psychiatric problems that they have in their lives, including substance use disorders, is just intended to work flexibly without unnecessary state interference. And there's a funny thing when it comes up to, just one last point, because I want to hear other thoughts too, but there's a funny element of the DEA's involvement in the prescription of buprenorphine, for example, that Dr. Singer brought up. When I was an intern in medical school, I could write a prescription for morphine, no problem. But at that time, I couldn't write a prescription for buprenorphine because it had that funny X waiver. Now we're done with the X waiver, but we still have a lot of systems and policies in place that treat addiction treatment as if it's somehow separate or apart, as if it's not the province of general physicians, of general medicine. And that's just false. There's a lot that general practitioners can do and all sorts of other medical providers can do to help meaningfully with addiction. I can tell you as a psychiatrist that it's one of the most rewarding things that you can do, even if it's not your primary focus. So, Brent, you asked, have we learned nothing? I think, we've learned a lot. There are a lot of actual practical medical interventions and other policy interventions we can do to save lives. And we have to be attentive to the things that get in the way of putting that knowledge to use.
So similar question for you, Jeff, with all of the data, with all the technology, with all the information, more information than ever at our fingertips. Are you optimistic moving into the future that we'll actually be able to make a change in this arena?
Sometimes I am and sometimes I'm not. What I'm seeing is a begrudging recognition that harm reduction, the United States lags behind most of the developed world on harm reduction. There's a substance use problem in Europe, just like there is here, but there are not nearly as many overdose deaths per capita in countries in Europe because they put a big emphasis on harm reduction. And in our country, we tend to have these leftover puritanical moralizations. So harm reduction is viewed by a lot of people as you're just enabling people to do something that's wrong. But we're seeing more and more states now, for example, take fentanyl test strips or even the word testing out of their drug paraphernalia laws. And this is red states and blue states. My state did it 2 years ago. South Dakota did it a few weeks ago. So even Governor Abbott of Texas has said he's changed his mind. He thinks fentanyl test strips should be legalized in Texas. So on the one hand, these are encouraging signs. And you have legislators, bipartisan, like I mentioned about the Methadone Act, the Modernizing Opioid Addiction Treatment Act. That's encouraging. But on the other hand, there are just as many voices clamoring for things like, well, we need to invade Mexico and really go after these drug cartels, basically do to Mexico what we did to Iraq. And I've argued that'll just leave us with Afghanistan. But it's not going to work, but it's going to, of course, destroy a lot of people's lives, kill a lot of people, destabilize our neighbors to the south, and fuel the development of even more potent drugs to smuggle because of the risks being taken. So you got those two things going on at the same time. You got one on one side, you got people pushing for, let's just double down even harder. And on the other side, you got people saying, well, maybe we can give in a little bit on this harm reduction thing. But I am told, as a person who spends a lot of time speaking to congressional staff when I go to Washington and I have visits on the Hill, that harm reduction, at least with a certain segment of the population, has negative connotations. That I should avoid. That I'm advised to avoid using that term, harm reduction, because when some people hear that, they immediately recoil, and that's like I say, a mixed predictions.
Sure. So Carl, in your book again, you mentioned that, first of all, statistically, in the U.S., only about 5% of patients with substance use disorder actually admit a problem and seek treatment. And you mentioned that a number of people will indulge in drugs, alcohol, and they don't have addiction problems. So the question arises, ethically, do we have the right to tell people, don't use these substances? Are we, and I quote what you said, are we over pathologizing everyday life?
I think there are a lot of ways that societies can translate messages about drugs and drug use, and those messages don't always have to be translated through prohibitionist policies or through criminal justice mechanisms. There are ways, in other words, for us to communicate reasonable information about drug harms without turning it into an all or nothing crackdown punishment approach. It actually, in Southern Europe, this is something they do quite well. And there have even been studies looking back over the history of alcohol policies and the way people understand alcohol problems from North to South Europe, and that in Southern Europe, people have a different theological notion of free will. They're less likely to ascribe their problem to their individual choice and self-control. And that's really fascinating, because it shows that it's not just a matter of disciplining yourself. There are ways that societies can communicate that drugs are harmful, drugs are sometimes things that need to be avoided, without necessarily making it into a criminal punishment. The word that sometimes is kicked around in drug policy circles is grudging toleration. We can tolerate these drugs, but we can also institute common sense policies to in a way communicate and protect people against the worst harms.
Jeff.
Yeah, I'd like to actually also cite the thoughts of one of Dr. Fisher's colleagues at Columbia, although he's in the psychology department, Carl Hart. And I think it's important for us to realize that we kind of arbitrarily decided that some drugs are bad. And a lot of that actually has its root. For example, we made opioids bad largely because of Chinese immigrants who were using opium. Cocaine was associated with, there were New York Times headlines in the 1920s talking about quote unquote cocaine crazed Negroes who became impervious to bullets. And a lot of people in the Northeast who upset by the competition from African Americans moving from the South to the North in search of work. And they were willing to take on work really hard for low money. They must be using cocaine. That's the only way they could work this hard and kind of outcompete us. So there's a lot of marijuana as well. It's called marijuana, not cannabis, for a reason. So I think every one of us would agree that alcohol can be dangerous and that long-term heavy use can cause a lot of organic damage. And some people develop alcohol use disorder, but there's an awful lot of people who get a lot of pleasure out of alcohol and they use it moderately and sensibly. And I personally think that we don't need to arbitrarily say all of these currently unapproved drugs should be unapproved, because there are an awful lot of people who get pleasure out of using these drugs recreationally in moderation. I'm talking about the illicit drugs. There's a lot of evidence on that, and I'm sure Dr. Fisher would agree with me, and that we should therefore focus on take the same approach that we take towards alcohol, which is educate people on how to use these drugs more safely, how to practice harm reduction. For example, with alcohol, it's commonplace now to ask to have a designated driver if you're planning to, imbibe more than is safe at a party, those kind of things. of course, setting age limits and DUI restrictions. But I don't know why I don't think we should select out anybody who uses any of these drugs as having a problem. A lot of them don't have a problem. They're getting pleasure out of it and they're using it on occasions. And we should realize that.
So I'd like to dig down just a little deeper into harm reduction itself. As you mentioned, there's some resistance out there. It's becoming the gold standard, I would say, within the medical establishment, but we hear a lot of criticism from various factions. So I'll give you an example. I think it's in terms of pitting harm reduction against abstinence. And one of the arguments that you hear in terms of one of the things you're talking about, which is the safe injection site. Okay, so if you have a situation, and this has been brought up, if you can buy drugs across the street, then come and use them inside. Why would anyone want to get clean under those circumstances? Where would be the incentive?
Well, you want me to answer this one?
Oh, let everybody.
Sure. And that's a common refrain. Again, harm reduction harm reduction doesn't have anything to do with abstinence. It's non-judgmental. It's saying, let me offer you ways to reduce the harmful effects of what you're doing. And so it's realistic. Requiring, not everybody can abstain, and I'm sure Dr. Fisher knows more about this than me, but the abstinence-only programs have a very high recidivism rate. If it works for people, that's wonderful, and I'm really happy for them. But most evidence suggests that probably the most successful programs are medication-assisted treatment, which actually is not abstinence per se, right? It's replacement, preventing withdrawal symptoms and allowing people to kind of stabilize their lives, which oftentimes has a whole lot of other beneficial effects, because so much of addiction is kind of responding to it's automatized responses to certain stress triggers, and removing the stresses kind of helps recovery. But there's no evidence, and just think about it, defies logic. Does anybody here think they've been dying to shoot up heroin and find out what it's like, but they're afraid to, now that there's a safe consumption site nearby, they're going to go in and do it? Come on. So
another argument that we hear is the concept with harm reduction is basically you have sobriety. In a sobriety situation, abstinence, you are surrounded by clean folks, you become one of them. With harm reduction, you're surrounded by users, implying, oh, that's okay, and perhaps this is all you'll ever be. You have no obligation to take it any further. So there's the question, to break people out of their dependencies, is this just normalizing their behavior, or are you actually able to change them? So
let me speak to that for a second, because I've got some clinical experience, and also when you look at the historical arc of it, I think it could be helpful. I'm in addiction recovery. I went to rehab. Some of the most harmful messages I ever got about addiction were from some of my fellow patients in rehab, which was a controlled environment where abstinence was being enforced. So I don't know that somebody's use status in the moment is necessarily saying a lot about how people formulate their identity and how they manage their health behaviors. I think I'm with Dr. Singer that, we have to be careful about the use of the word harm reduction. Harm reduction at this point has been around since the 1980s. People mean drastically different things by harm reduction. From one standpoint, harm reduction means a social movement that is about overturning existing hierarchies and putting power back in the hands of users. But I think for us as physicians, in the medical context, there's a more narrow definition that is useful, and these things coexist. They exist at two levels at the same time. The other definition of harm reduction is just, what if we took as our yardstick how to save lives and take care of people? And in an immediate one-on-one clinician encounter, what that means is giving up the fantasy that we can control people's behaviors. I often will recommend abstinence to a patient. I often have the assessment that abstinence is the best route for an individual patient. But if I went around, as many clinicians have and many treatment programs have, if I went around with the idea that I could somehow dictate how somebody behaves, then I would not be practicing good medicine. I need to take into account that people don't follow recommendations sometimes, as is also the case when you prescribe heart disease medications or blood pressure medications or diabetes medications. You just don't have a very high rate of abstinence. So given that that is the case, then what should we do? That's a very basic question that I think any good doctor would have to consider, but that is harm reduction. That's the first entry level kind of harm reduction that we need to practice.
I agree completely. And also I'm told by people that I've developed relationships with who operate these overdose prevention centers that that the fact that they're not, the people using these centers could feel that, can palpate that they're not being judged, and that there are people who are actually unconditionally care about them. They just want them to live, and that they mean something to them. Has that connection, which oftentimes people who have substance use disorders, especially those on the streets, have been lacking for a long time. That really helps them recover, helps get them into programs.
And on that note, there's also been some criticism that sometimes stigma is good. Do you think there's any credence to that?
Well, let me say something about that. I was just talking to Owen Flanagan, who was the chair of philosophy at Duke University, a major philosopher of addiction, and he is also in addiction recovery himself. And he has come out with the notion that shame has gotten a bad rap, that we get too lazy with our use of the word shame. And of course, it's bad to have stigma. But let me just take my own perspective. If I've caused harm to people, even just through insensitivity or negligence, they're just in a personal context, medically. But if I've caused harm to somebody in the course of addiction, there's an appropriate kind of shame there. There's an appropriate kind of responsibility. It doesn't mean that people should scold me in a medical context or otherwise, but it does mean that we have to think carefully about we should not reduce addiction or other drug problems to some sort of all or nothing binary, that people, once they develop drug problems, they become dehumanized zombies and they have no control. It just doesn't work that way. So I think we can hold, like, if we're smart about it and we take ourselves seriously and we take our patients seriously, I think we can hold those two things in mind. We can destigmatize and we can counteract the negative messaging about drugs and drug users, while also simultaneously recognizing that it's complicated and that it does involve these big questions like responsibility and recovery.
One final area.
I agree completely.
Very good. So do I. Recidivism, the term keeps coming up. And as you've mentioned, through evidence-based medicine, we see that medication-assisted, now MOUD they call it, is fairly effective, but yet still there's a lot of recidivism even within that arena. And with abstinence and 12 steps and those traditional programs, they'll argue, well, that's because we don't collect the data, because we're anonymous. So the question out there, and I feel this frustration in the work that I do in the field, that there is just a high recidivism rate no matter what approach we take. Any thoughts moving forward on how we're going to make a difference in terms of that?
It's a very, addiction is very complicated, and each person's route to addiction, a lot of them every person has got their own unique story that is fueling it and animating it. I think we just have to get used to the fact that, like with many disorders that we treat, disorders or diseases, I don't subscribe to the disease model here, but whatever disorders we treat, sometimes one method doesn't work, we have to try others, which is why I think we should do things like, for example, move heroin or diacetylmorphine onto Schedule II, so we could see if in some cases, if methadone doesn't work, maybe heroin-assisted treatment works. We should remove government obstructions to clinical research on other modalities of treatment.
Carl,
final word.
Yeah, I'll just say briefly, I like what you had to say about that. I would say the word that jumped out at me, Brent, was frustrated. You know, I see clinicians and I see policymakers who are really, really frustrated to the point of burnout, to the point of despair, to the point of hopelessness. And I think that is also a systemic problem and has to do with how we take care of ourselves and how we take care of each other in the medical profession. And burnout is not just a matter of I need a spa weekend or I need a pizza party or I need a lighter patient load. It also speaks to our ability to take care of the overall system. When we as clinicians and providers and otherwise feel disempowered, or we feel like antiquated drug laws, like paraphernalia laws, or like a lack of access to naloxone, or things that get in the way of common sense testing, when all that stuff obscures our ability to enact common sense public health measures, then that can lead to a sense of frustration. That's burnout too. So I think, when we accept that relapse is a part of life, it's a fact of life for some people, then again, the question becomes, then what do we do? Then how do we take care of the whole spectrum, the whole situation? And I think that that's why medicine has a role to play in considering these bigger questions.
Dr. Carl Fisher is author of the book, The Urge, Our History of Addiction. Dr. Jeff Singer is Senior Fellow at the Cato Institute. Thanks, both of you guys, for this provocative, very interesting discussion.